Good day everyone. Today we will be discussing about the drug named nitrofurantoin. Nitrofurantoin comes under the pharmacological category of nitrofuran antibiotic. Nitrofurantoin's mechanism of action has remained poorly understood since its discovery in the 1940s. Nitrofurantoin uses several mechanisms to achieve an antimicrobial effect. Nitrofurantoin is taken up by bacterial intracellular flavoproteins that reduce nitrofurantoin to reactive intermediates. Intermediate metabolites resulting from this reduction then bind to bacterial ribosomes and inhibit bacterial enzymes involved in the synthesis of DNA, RNA, cell wall protein synthesis, and other metabolic enzymes. The broad-based mechanism of action may explain the lack of acquired bacterial resistance to nitrofurantoin. Nitrofurantoin is an antibiotic medication that is used for the treatment of uncomplicated lower urinary tract infections. It is effective against most gram-positive and gram-negative organisms. The FDA approved nitrofurantoin in 1953 to treat lower urinary tract infections. Several major guidelines have recently declared nitrofurantoin the first-line therapy for treating uncomplicated lower urinary tract infections, increasing resistance to newer antibiotics coinciding with an increasing prevalence of extended-spectrum beta-lactamase or ESBL producing bacteria has led to a resurgence in the prescriptions of nitrofurantoin. Nitrofurantoin's primary use has remained in treating and prophylaxis of urinary tract infections. Nitrofurantoin is advantageous as it concentrates in the lower urinary tract while maintaining a low serum concentration and does not significantly affect bowel flora. The predominant cause of urinary tract infections is periurethral colonization of bacteria from a fecal reservoir, which then ascends the urinary tract. Researchers think that nitrofurantoin's continued effectiveness and minimal resistance patterns are partly attributable to its minimal effect on bowel flora. Nitrofurantoin is effective against many gram-positive and gram-negative organisms. Nitrofurantoin is bactericidal against most common urinary tract pathogens, including Escherichia coli, Enterococci, Klebsiella, Staphylococcus saprophyticus, and Enterobacter. Its spectrum of susceptibility also includes Shigella, Salmonella, Citrobacter, Neisseria, Bacteroides, Group B Streptococcus, Staphylococcus aureus, and Staphylococcus epidermidis. Studies have shown the effectiveness of nitrofurantoin does not differ between ESBL-producing E. coli and non-ESBL-producing E. coli strains. Numerous studies demonstrated that nitrofurantoin is an effective prophylactic agent in long-term prophylaxis and compares well to other antibiotics. A population-based survey of in vitro antimicrobial resistance of urinary E. coli isolates among United States outpatients showed a resistance rate of 1.6%. A meta-analysis for clinical cure demonstrated overall equivalence between nitrofurantoin and its comparators when used for uncomplicated urinary tract infections. Nitrofurantoin is a relatively safe drug compared to alternatives. Comparator drugs such as trimethoprim sulfamethoxazole and ciprofloxacin often have more reported side effects than nitrofurantoin. The most commonly reported adverse drug reactions are nausea, vomiting, loss of appetite, and diarrhea. These symptoms usually develop in the first week of therapy. Modern formulations, specifically the macrocrystalline form of the drug, have less frequency of these effects due to attempts by manufacturers to alter the crystal size, which affects gastrointestinal absorption. The most well-known severe reaction is pulmonary toxicity. Pulmonary toxicity caused by nitrofurantoin can be categorized into acute, subacute, and chronic pulmonary reactions. Acute pulmonary reaction syndrome is characterized by sudden onset of fever, chills, cough, myalgia, and dyspnea. Subacute pulmonary reactions also occur and are characterized by persistent dry cough, dyspnea, and fever. This chronic pulmonary reaction is associated with the insidious onset of persistent dry cough and dyspnea. Acute, subacute, and chronic pulmonary toxicity is reversible with immediate cessation of the drug. This effect remains uncommon, with one study showing the calculated frequency for all pulmonary reactions were only present in 0.001% of nitrofurantoin courses. The severity of the nitrofurantoin-induced liver injury ranges from mildly symptomatic elevations in serum aminotransferase levels to cholestatic jaundice, hepatitis, and hepatic necrosis. Nitrofurantoin can also lead to fulminant liver failure and death. The drug should be ceased immediately in these cases. Complete recovery is expected, but recovery is slow, that is, 2 to 6 months. In rare cases, chronic liver injury persists. Because of the autoimmune features of many cases of nitrofurantoin hepatotoxicity, corticosteroids are frequently used, especially in chronic and severe cases. However, the ultimate therapeutic efficacy of corticosteroid therapy is not yet established. In addition, caution is advised with corticosteroid therapy due to the risk of relapse. Peripheral neuropathy is another known rare adverse effect and is mainly associated with prolonged use in patients with poor renal function. Typically, nitrofurantoin-induced neuropathy is link-dependent sensorimotor polyneuropathy. There is moderate to severe abnormal sensory and motor conduction in NCS or nerve conduction studies, and axonal degeneration on sural nerve biopsy. However, it is important to note that non-link-dependent small fiber neuropathy that is not dose-dependent nor associated with impaired renal function has been reported. In addition, the skin biopsy demonstrated clustered terminal nerve swellings, without evidence of nerve fiber degeneration. There is no information in the manufacturer's labeling regarding the use of nitrofurantoin in patients with hepatic impairment. However, nitrofurantoin is contraindicated in patients with a history of cholestatic jaundice or hepatotoxicity. According to the manufacturer's labeling, nitrofurantoin is contraindicated if creatinine clearance is less than 60 ml per minute. Administration of nitrofurantoin in neonates and patients with glucose 6-phosphate dehydrogenase deficiency is contraindicated due to the potential risk of hemolysis. Nitrofurantoin should not be administered to patients with acute bacterial pyelonephritis as nitrofurantoin does not reach therapeutic concentrations in the upper urinary tract, and bacteremia often accompanies this disease. Patients with anuria, oliguria, or significant impairment of renal function should not take nitrofurantoin. A retrospective chart review suggests that a cutoff of CrCl less than 40 ml per minute would be more appropriate. The drug is contraindicated in pregnant women at term, during labor and delivery, or when the start of labor is imminent, and is also contraindicated in neonates younger than 1 month of age. This is because of the possibility of hemolytic anemia caused by immature erythrocyte enzyme systems, specifically glutathione instability. Nitrofurantoin is contraindicated in men with urinary tract infections as these infections are often related to prostatitis, and nitrofurantoin does not penetrate prostatic tissue effectively. Nitrofurantoin is identified in the Beers criteria as a potentially inappropriate medication to be avoided in patients 65 years and older due to its potential for pulmonary toxicity, hepatotoxicity, and peripheral neuropathy, particularly when given long-term. As per the manufacturer's labeling, patients on chronic nitrofurantoin should be monitored regularly for changes in renal function due to the increased risk of peripheral neuropathy. It is also essential to closely observe the pulmonary function of patients on long-term nitrofurantoin therapy. Also, clinicians should periodically obtain liver function tests as hepatotoxicity may be asymptomatic in some cases. Thank you. Kindly comment for further queries and doubts.